Hey.
How are you?
Hey, Rachel.
Good morning,
I
everyone.
already
I
have
think
a
we
coat.
are ready to start our next session on using state data to support your quality improvement efforts in your region. So uh, my name is Jimmy Blanton. I'm with the Healthcare Quality Institute at the Health and Human Services Commission. And this is the third statewide learning collaborative that I've been able to attend and been a part of. And I got to say, with all due respect for the other two, and those were really great conferences and great events, I think the one that we're having this time has been the best one. And the reason for that is it goes back to something Ardas mentioned in her opening remarks yesterday, uh, where in the past we've had great examples of all the excellent work that's being done out in the regions in our RHPs, but now we have data, and it's still early, and we still need more data points, but having that data has allowed us, I think, to have some really fruitful conversations. And let me see if I can get this to advance the right direction. I'm clicker challenged. How do you get this thing to work? There we go.
Help.
Help.
Tech help.
Oh, yay. It worked.
All right, someone with some technical skills is going to need to give me a little tip on this particular clicker.
Backwards. Oh, you do see this slide. See?
Yeah, that's excellent. If I
Yeah.
look down.
Help.
Well, at any rate, what we're here to talk about today is data and how to use the data and how important it is to manage the work that you do. I think the first slide that I have up here, if it pops up, is are from a couple of healthcare quality improvement experts generally. Peter Drucker, who has his famous saying that we cannot manage what we cannot measure, and then a quote from Judith Hibbard that which is measured tends to improve, and that which is measured publicly tends to improve faster. Now, these were the leading kind of foundational ideas from our first Quality Institute publication, and I think that they are very true, and that's why I'm really grateful. Here we go. I think we've got it going now.
Hope so. Hopefully that's it.
Hopefully, thank you. I'm really grateful today to have an opportunity to share with you a great panel that we have from our Health and Human Services Commission, some of our best and brightest who work in the area of analytics, among other things. And hopefully they'll be able to tell you some of the work that they've been doing to support your efforts and give you some ideas that you'll be able to take back to your regions to use in your own quality improvement efforts. So data is really sort of the underlying topic of this, but what's the lens that we want to look at that through? And I can say that I've been, for the past 21 years, I've been at the Health and Human Service system, working with various agencies and various data sets for the most part in data analytics for almost all of my career. The last 4 years, I've had the opportunity to work with the Quality Institute, and in that role, I've been able to work with some of our greatest leaders in our state and the healthcare system, some of our leading experts. We reviewed a number of topics, made recommendations for improving care in those areas, from palliative care to transparency in the healthcare system. But whatever the topic that we're looking at, whatever the group of experts we're working with or stakeholders, the goals that we are pursuing, the aims that we're pursuing for quality improvement remain the same. And those are better care, smarter spending, and healthier people. And this is the famous triple aim of course, or at least the version of it that's been adopted for the National Quality Strategy, and also by CMS in their work. Now, preparing for this event, I did a little more research on the triple aim, and I found that when you Google the triple aim, you actually can come up with literally dozens and dozens of different variations on the same theme. But as far as I know, this is the original version that was devised by Don Berwick and his colleagues at the Institute for Healthcare Improvement back in 2008. Now, so this is not actually this is a relatively new idea, only 8 years ago when this was put together in this format. But the individual aims themselves, improving the patient experience of care, improving the health of the population, and reducing per capita costs. Those are of course are not new ideas, but the real insight that Dr. Berwick and his colleagues had was that these are goals that need to be pursued simultaneously, that there's not necessarily a trade-off between quality and cost, that very often higher quality care leads to lower overall costs in the healthcare system. I think that's a theme that I've heard in many of the dialogues that we've had over the last day and a half. But yet it's still really an ambitious goal that the triple aim recognizes that no single sector can really achieve by itself. So the triple aim really calls for strong collaboration across all the entities and all the stakeholders involved in supporting quality health and quality health care for the population, from healthcare organizations and providers to public health departments, social service entities, employers, schools. It's really a health in all systems approach. We need everyone. But within this collaborative structure, there has to be an entity to bring these groups together. And the triple aim, Berwick calls them conscientious integrators. For me, in Texas, I like to think of them as RHPs, or RHP anchors, and because a lot of the work that I see that you've been doing is bringing these stakeholders together to look at the needs in your regions and to come up with a structure to create collaboration, to identify goals, to come together in events such as this to promote learning so that we have a learning healthcare system. And also, back to our topic, to measure progress, to make sure things are on track and that we're meeting our goals, both at a population level and at specific project level. So again, that brings us back to the topic for our panel today. And I'm not going to go over in depth this particular slide, only to say that we're going to cover all of these ideas in the presentations that you're going to hear. And that really, when you look at these measurement principles for the triple aim, they're really the same list that you would see. They're good measurement principles for any kind of work that may be going on in terms of quality improvement. And also just to point out again that within the AAA, there's an emphasis not just on measuring what's happening at a project level, but also at a population level. So we need to, you heard yesterday that we've started working on a statewide analysis plan that's looking at each region and what kind of performance is going on there. So we're really, I think, within our program and the work that you're doing, trying to create these AAA entities across the state. And I think that's really important. It aligns with the National Quality Strategy. It aligns with CMS and their strategies for quality improvement. So for now, that's enough of me. I think we're going to introduce our first panelist. And you see our learning objectives for today, but our first panelist is Noelle Gahn. She is a senior policy advisor for the Healthcare Transformation Waiver Team. She has a master's in public affairs at University of Texas LBJ School, which is the same degree that I have, so it's a great degree. Everyone on that team, they do a lot of different things. They have a lot on their plate, but one of the things that, I think is near and dear to her heart, where she puts a lot of time, is working on these Category 3 and 4 quality measures. And we have, I think, over 1,400 projects, and they all have measures. And if you talk to Noelle, I think you'll start to think that maybe she knows every one of those measures by memory and by heart. So she's just a wealth of information on that, and she's graciously put some of that information down in a presentation for you so that you can see some of what she's found to be the most interesting outcomes that she's seeing right now. So, Noelle?
Thank you, Jimmy. My name is Noelle Gahn. I work on the waiver team, primarily on Category 3, along with Diana Clark, who's on the panel with me today, and also Sheila Hughes and Rebecca Faulkner, and support from our great team, Natalia Leone and Sherry Richardson, who's helped us schedule more technical assistance calls than I thought were possible. I started working with the waiver team in January 2014. So this was when the final Category 3 framework and menu had been agreed upon with CMS, but before the compendium was published and before measures were officially selected. Much credit for this work goes to Jennifer Woodard, who was instrumental in getting the impossible off the ground. I know she couldn't make it to join us today, but she's probably watching. As Ardas said yesterday, Category 3 is a miracle, or at least some days it feels like a miracle. Some days it feels more like one of the 12 labors of Hercules. And if you recall, one of those 12 labors was cleaning the Aegean stables, which were stables full of mythical cows. So that is my cow joke to start out. But we're here today to talk about the many successes providers are seeing in Category 3. So we're going to go with, today, Category 3 is a miracle. And it's certainly been a lot of work, as we saw in the last panel, and have providers been talking about sort of throughout the conference. Now I'm going to see if I can make this work. So just a quick outline of what we're going to look at. I'm going to give you a quick overview of Category 3. Category 3 is very weedy in terms of policy. We actually like to say we're not just in the weeds, we're planting weeds. We're going to look at the overall Category 3 success and then take a quick look at some of the successes by outcome and then by project area as well. So a quick Category 3 overview. This will be very familiar to many of you, but totally foreign to some others. Each district project must have at least one associated Category 3 outcome. We have 2,111 active Category 3 selections, and those are among 251 standardized outcomes. We have $805 million pay for performance, all funds, in Category 3 available to be earned in demonstration year 5. Outcomes were selected by providers from a predefined menu, developed with provider input and approved by CMS. It's also worth noting that many of these outcomes were selected after projects were picked. Each outcome is related to a district project, but generally measures improvement at a level broader than the district project intervention. One district project can have more than one Category 3 outcome, and conversely, providers may report the same outcome for multiple district projects. Most outcomes in that 2,111 are pay for performance, but some are pay for reporting. All pay for performance outcomes have achievement goals that must be met to earn payment, and providers can earn partial payment for achieving 25% of a goal for a given performance year. So that is the speediest Category 3 overview possible. Outcomes in use include primary care, behavioral health. Did I go the wrong way? Primary care, behavioral health, ED utilization, hospital readmissions, hospital infection rates, patient satisfaction, public health, quality of life measures, and others. The majority of outcomes are measured at a facility or a system level, so generally something broader than their district intervention. Roughly 10% of measures are reported specific to a payer type. And we've referenced our most common outcomes, I'm sure a couple times in this week. The most common outcome being the HbA1c. Currently, 25% of providers are reporting on this outcome for at least one project. controlling high blood pressure, 21% of providers are reporting on this outcome for at least one project. ED visits for ambulatory care sensitive conditions, 18% of providers, and risk-adjusted CHF readmissions with 11% of providers. Baselines for these outcomes were reported in demonstration year 3. Most of these baselines are 6 or 12 months of data set somewhere between the beginning of 2012 and the end of demonstration year 3. So not everyone is using the same measurement period in terms of reporting their baseline and performance. So in category 3 lingo, we refer to these measurement periods as baseline and performance year. So not everyone's using the same performance year. 88% of pay-for-performance outcomes have reported performance year 1, and 12% of pay-for-performance outcomes have reported performance year 2. So we are starting to have multiple data points that we can look at. And performance will be reported for the same outcomes through demonstration year 6. A couple of analysis considerations that are sort of obligatory as we start to look at how different outcomes are looking up against each other. The numbers presented are preliminary. There are outcomes still to be reported and a number of factors that could change. Identical rates, again, are reported for multiple projects or outcomes. So if we're looking at all of the HbA1c outcomes, 4 of those might be the exact same number that a provider is reporting for multiple projects. Making comparability between projects is difficult. All of our district projects are sort of unique in their denominator size, in who they're measuring, and of course, category 3 does not exist in a vacuum. So there's a lot of other things going on that are touching on these outcomes. Most pay-for-performance outcomes will report 2 years of performance under the current waiver. Some will report only 1, and those are excluded from what we're talking about today. And that's primarily due to delays in project approval or data collection. And for those of you who are very familiar with our Category 3 weeds, we're not going to be talking about population-focused priority measures, which is another small subset of outcomes for those of you that are helping us plant weed seeds. A couple terms we're going to be looking at today. When we say success rate for Category 3, we're looking at the percentage of pay-for-performance outcomes that have reported at least 25% achievement, so received some payment for improving on their outcome towards their goal for a given reporting year out of all outcomes that have reported to date. When we talk about gap closure, this is how we're measuring that percent improvement. This is the percent of the gap closed between baseline and perfect, and this is similar to how our Category 3 goals are set. So we're trying to use that same language. So if we're talking about a 5% goal and we see a median improvement of 10%, we're using that same calculation. So when we're looking at outcomes altogether, we're looking at the median reported gap closure. So that's the median percent of improvement between baseline and perfect for outcomes that have reported at least 25% achievement or successful outcomes. When we look at project areas, we're going to be looking at the percentage of common outcomes that are high achieving. So we're looking at the percent of common outcomes with a gap closure that's above the median for that particular outcome out of all common outcomes that have reported successful achievement. And when we say common outcomes, there's a lot of outcomes within Category 3 that sort of have maybe 2 people reporting on it, and that's not enough to make any sort of comparison. So we're looking at just those that are the most common outcomes under each project area. So here's where we are today, our overall Category 3 success rate. You'll see we have 1,723 pay-for-performance outcomes. 1,376 have reported their first year of performance, and you'll recall that there are, I think, a few hundred that we don't expect to report that performance year 1. They'll be catching up in performance year 2. So this is about 88% of the data that we expect to see for performance year 1. For all pay-for-performance outcomes, we have a success rate of 81%, which means that 81% of outcomes that reported pay-for-performance outcomes that reported performance year 1 have reported at least partial achievement. And in that number, actually, the majority of outcomes are reporting full achievement. So we have 72% reporting full achievement of their goal, and about 8%, 7%, 7% or 8% reporting partial achievement. In performance year 2, with the limited number of outcomes we have reporting, we see that the success rate going up a little bit, but underneath that, you'll see that the number of outcomes reporting full achievement goes down just a little bit, and this isn't on the slide, I'm just telling you this. It's 68% reported full achievement in performance year 2, and 17% reporting partial achievement. So that's a good overview of where we are today, and you can also see the breakdown by provider type with a little bit of variability in there. And one of the idioms that my mom raised me with was, if you're not hearing no, you're not asking enough. And I know that that's I know it's a little painful for providers, but I think it's a good thing that we see that we're not 100% achieving on all of these, because that means we're actually asking for meaningful improvement, and that you guys are doing really tremendous work in improving these health outcomes in Texas. So kudos. And this is how it looks like if you were to break down all the outcomes by outcome domain. So each category 3 outcome is grouped into one larger outcome domain. Primary care and chronic disease management, which is outcome domain 1, is the most common. We have 395 outcomes under that domain that have reported performance year 1 with an 83% success rate, followed by that outcome domain 9, which is right care, right setting, and that's sort of ED visits, and that also includes criminal justice readmissions in that measure. We see the highest success rates in the palliative care, domain 13, as well as oral health. And we see that the most challenging outcome domains are PPAs, cost of care, which is OD5, although that's probably too small of a volume to really be significant, and patient satisfaction in outcome domain 6. But you do see that the majority of outcomes are seeing improvements in performance year 1. And this is a list that is available online, so I'm not going to go through all of it, but these are the most common standalone pay-for-performance outcomes, excluding surveys and tools. So we can sort of look at them all together. The first column of numbers is the number of pay-for-performance outcomes that have reported performance year 1. The second column is their success rate, with a darker green indicating a higher success rate. And the final column is the median gap closure. Again, this is available online, so you can look at it in your quiet time later today if you're interested. And we're going to take a closer look at some of the outcomes in red specifically. So diabetes, HbA1c, this will not be the last time I say HbA1c in this presentation. We have 106 outcomes that have reported a baseline with an average rate of 44%. And then in performance year 1, we see that average improving for those that have reported to 36%. And that translates to a 74% success rate and a 17% median gap closure. And we see those numbers increasing a little bit with the few outcomes that have reported performance year 2. This outcome is reported by all of our provider types, so hospitals, academic health science centers, community mental health centers, and local health departments. We know it's a challenge sometimes to bring this into a new setting, particularly the behavioral health settings and the local health departments. The most common project areas reporting on this outcome are expanding chronic care management, expanding primary care capacity, enhancing and expanding medical homes, and implementing chronic disease registry. And yesterday we saw Lance Ames with South Texas Health System talking about this outcome in the patient-centered medical home. And you'll see that for the project area related to patient-centered medical homes, we have a 100% success rate and a 20% median gap closure. The next, went too far. Okay. Controlling high blood pressure is the second most common outcome. This is reported again by all of our provider types, and this is a number that should go up with improvement. So we see an average baseline of 57% and performance year 1 average rate of 64%, with similarly an 84% success rate, 11% gap closure, and then those numbers going up again in performance year 2 for the few outcomes that have reported. The most common project areas are expanding primary care capacity, integrating primary care and behavioral health, and expanding chronic care management. Interestingly, behavioral health providers, so regardless of the project option that they're reporting for this, are reporting a higher success rate and a higher median gap closure as compared to non-behavioral health providers. And a lot of that has to do with starting from behind, really. So if you were to look at the average just for the behavioral health providers, you would see that that average starts lower and that they're improving on that in greater numbers. Reducing ED visits for ambulatory care-sensitive conditions. This has certainly been a more challenging outcome for providers, and it's one that we're finding is impacted by the ICD-9, ICD-10 transition in demonstration year 5. So we'll probably have to be talking to some of you about that in the future. A 66% success rate with a median gap closure of 7%. And this is reported again by all provider types. It's a big challenge for behavioral health providers and local health departments who often are reporting this with someone else's data. And the most common project areas are that expanding primary care capacity and patient care navigation. Risk-adjusted all-cause readmissions should be coming up next. This is not sensitive. We have 56 outcomes that have reported, and here again, they're looking at a ratio. It's a complicated number to get to, but it's a ratio of that actual to expected number of readmissions, with a number over 1 indicating that your readmissions are higher than expected, and a number below 1 indicating that your readmissions are lower than expected. So we see a 75% success rate and a median gap closure of 10%. This outcome is reported by hospitals only. And yesterday we saw Dr. Oliver with Parkland talking about their experience with this measure. They're reporting on this measure for a number of their district projects, and actually many of the providers reporting on this outcome have multiple district projects that are connected to reducing readmissions. So it's actually half of the providers reporting on this outcome are doing it in some sort of connected effort. Criminal justice readmissions. This is a measure that was developed by DSRIP, or developed for DSRIP by the Department of State Health Services, and it requires data from local jails. I don't spend a lot of time in your EHRs, but I'm pretty sure most of them do not tell you who has been arrested and when and for what. So this is a challenging measure for providers to track. It requires getting data from another entity if it's your and sometimes that's easier to access than others. But we're seeing really high success rates with this outcome. It's a really meaningful outcome and one that we're really proud to have in DSRIP. Of the 18 outcomes that have reported performance year 1, 93% have reported an improvement in the number of criminal justice admissions over their baseline, with a median gap closure of 47%. So we're really seeing these projects moving the needle a lot. The most common project areas here are the targeted behavioral health intervention and behavioral health crisis stabilization. And this can come in a lot of different forms. We see mental health officers, MCOT projects, drug and alcohol interventions. Dr. Gilmore yesterday spoke about this measure at the Amarillo Recovery from Alcohol and Drugs program. So a lot of different types of behavioral health interventions are reporting on this particular outcome. Follow-up after hospitalization for mental illness. This is one that we're really happy to see sort of broad success with the providers that are reporting this. This outcome has 2 parts, the 7-day and the 30-day rate, and we're seeing improvement in both of those numbers. This outcome is reported by all provider types. And interestingly, as our DOS mentioned yesterday, this is an outcome that we're seeing move statewide in the Medicaid data also. So this is one of the measures that ICHIP, who is our external quality review organization, is looking at in their statewide analysis. And we're seeing not only improvements with district providers, but we're starting to see improvements in the rates of 7-day follow-up in the Medicaid population as well. And reducing ED visits for diabetes, this is not a common outcome, but it's one that we're seeing very high success rate among those providers that are reporting it. We see a 93% success rate in performance year 1 with a median gap closure of 16%. This is reported by hospitals and academic health science centers. And the most common project area here is patient navigation. And that is one more. This is the percent of low-weight births. We saw Deborah Chester yesterday with Odessa Regional Medical Center talk about her experience with improving this outcome as it relates to their gestational diabetes project. We have 12 outcomes that have reported performance year 1 with a success rate of 82% and a median gap closure of 20%. The most common project areas are expanding specialty care capacity and expanding primary care capacity. And that is the last of the outcomes that I'm going to blow through. And we're going to take a quick look at how these outcomes look when they're all grouped under an individual project area. The most common outcome here you'll see is expanding primary care capacity. So that's the most common district project. You'll see we have 221 category 1 or 2 projects that are expanding primary care capacity. 265 outcomes under that have reported performance year 1 with a performance year 1 success rate of 73%. And here's where we get to that percentage of high achieving outcomes. So we can see the outcomes that are under a specific project area, how far they're moving the needle as compared to other project areas reporting that same outcome. Integrated behavioral health and primary care, behavioral health crisis stabilization, and palliative care have the highest success rates. Integrated behavioral health and primary care also has the highest percentage of high achieving outcomes. And care transitions appears to have the lowest success rate, but we'll take a closer look at that to see what's going on there. Under expanding primary care capacity, you see we have 265 pay-for-performance outcomes reported and a 73% success rate. The most common outcomes are high blood pressure, reducing ED visits for ambulatory care-sensitive conditions, HbA1c, and breast cancer screening. And I'll say the first time I presented this last slide, the first question I got was, so what? What is behind those? What are those project areas actually doing to impact those outcomes, which is why we're sort of taking a deeper dive. And I won't go over all the numbers here in the interest of time, but know that these are available on the waiver website. Expanding specialty care capacity, we have 118 outcomes with a 78% success rate. The top outcome there is one that we haven't talked about yet in this presentation. It's that third next available appointment, which is sort of the only outcome that we have that's measuring improvements in this access to care. Enhancing and expanding medical homes, we have 55 pay-for-performance outcomes with an 89% success rate. And you'll see that among these most common outcomes, all of them diabetes, the HbA1c, diabetic foot exam, LDL screening, retinal eye exam, we see really high success rates and higher than average median gap closures. So we're seeing these patient-centered medical home projects being very successful with these outcomes that they're undertaking. Expanding chronic care management models, we have 85 outcomes with an 85% success rate, and the most common outcomes there look fairly similar to what we've seen. We see risk-adjusted, the CHF 30-day readmission rate, which is a challenging outcome, and the diabetes care, blood pressure control, and foot exam. Use of palliative care programs, this is one of those project areas that had one of the highest success rates, and we see a 91% success rate for the 54 outcomes that have reported performance. This is a sort of a mix of process measures and some of these more challenging clinical measures. Discussion of spiritual, religious, and existential concerns, treatment preferences, pain assessment, and then proportion admitted to ICU in the last 30 days of life. I think that's specific to cancer patients. Interdisciplinary family meeting within 5 days of admission to the ICU, and more than one ED visit in the last 30 days of life, which are really challenging outcomes. We only had 2 providers reporting on that one, but I wanted to include it because it's really worth celebrating. Care transitions, this is again the one that's looking to have the lowest success rate, but if you look at the outcomes under this care transitions, you see that they are really meaty, hard outcomes. The risk-adjusted all-cause readmissions, CHF readmissions, and ED visits for ambulatory care-sensitive conditions. And these are outcomes that we're seeing sort of all project areas really have to work to improve. Integrated primary and behavioral health care services. This again had the highest success rate and the highest percent of high achieving outcomes. And again here, let me get to my notes for this one. You'll recall from earlier slides that CMHCs had higher achievement levels for controlling high blood pressure and also had a lower baseline. So for both the primary care measures under this project area, the average baseline is significantly below the average baseline for all the other projects, reporting the same outcome, which could explain that, again, that higher reported gap closure. So how can we use this data? I know you all are using Category 3 internally and monitoring those outcomes as best as possible because a lot is sort of riding on them. But in looking at them as a whole, what's the point? We do use this as one way to identify strong projects and project areas. We know this is not the only one. Category 3 is sometimes a tenuous fit for specific projects, but it is certainly one tool that we have available to identify best practices and to facilitate sharing among providers. We have another panelist coming, Judy, who's going to be talking about a district project that's showing success in something other than their Category 3 outcome. So she'll show that it is possible. There are other numbers outside of Category 3. We hope that this is used to facilitate sharing of best practices. If you see that you're struggling with an outcome and a similar provider is reporting success, that's a place where you can make a connection and sort of figure out what you're doing differently and share your experiences. We're certainly looking at this as closely as possible as we plan for DY6 and as also we plan for whatever is beyond DY6. We do use this data both in terms of what you've selected to report on and how challenging certain outcomes are when we're looking at the MCO performance improvement project. So DSRIP had a place at the table to say these are what district projects are focused on. Here are some places where maybe we could align and then further align that Medicaid managed care. So reporting improvements on outcomes that are important to managed care organizations as well. And then we use this data to inform what we're looking for in the statewide analysis. So this is sort of a hint of this is what district projects are working on. Can we find these trends in the statewide data, in the regional level data? Do we see that these projects are moving the needle in a broader sense? And I will leave you with a couple links if you're looking at this online, and then a quote that I took from a recent article in the Odessa American regarding one of the district providers in RHP2, just to remind us that when we're talking about all these numbers are actually people. And so the goal is to reduce readmissions, but more than that, it's driven by the desire to do the right thing for the patient. And so we thank you for all the work that you're doing to do the right thing for the patient, and we hope that you're very proud of yourself because there's a lot to be proud of.
Thank you, Noelle. For our next speaker, we're going to move from the project level up to the population level. And our next speaker is Ayanna Clark, who's also with the Healthcare Transformation Waiver team and also does a lot of things for that team. She has a master's in public health from Texas A&M, but she's covered her bases. She also has a degree from the University of Texas, and so she's got those two major institutions covered with her education. Again, she does a lot of things, but one thing that's very important that she's been working on, she's been coordinating the development of a statewide analysis plan, and you saw some of the initial results from that yesterday when our EQRO presented. And so there's really some fascinating information in there that we hope to get out to you. So she's going to talk a little bit more about that statewide analysis plan and also let you know about some tools that are available for you. Looking at population health metrics and just have a discussion about population health in general. So, Ayanna?
Good morning. So on our way up here, Noelle asked me if I had a cow story or reference, and I hadn't thought of one, but I'm glad that I am going second because I did think of one while I was sitting here. So a fun fact about me is that both of my parents are from Honduras, and about 8 years ago, my eldest nephew came with us on a trip to Honduras for the summer, and one thing that he noticed as we were driving from the airport was that the cows were significantly smaller and skinnier in Honduras. And so his visual assessment was that the population of cows in Honduras looked very different than the population of cows in the US. So that's my little fun cow story. So I'm going to talk about population health, and this seems to be a theme that it's not new, and it's something that a lot of you all are working on and continuing to work on. So population health, I think, really captures and emphasizes what DSRIP projects and RHPs are doing together. And so now that we have Category 3 data available, and we also have some broader data availability with the statewide analysis, what do we do with that data? And how do we digest it? So population health, actually, before I continue, just a quick overview of my discussion. I'm going to quickly talk about population health and its importance, and then a discussion of DSRIP statewide analysis, and then a highlight of other health outcome data available to stakeholders, including DSRIP Category 4 data, and then some data that's available at the Department of State Health Services. So there are various definitions of population health, but it was first defined in 2003 as the health outcomes of a group of individuals, including a distribution of such outcomes within the group. And the different concepts of population health fall along its spectrum, ranging from the focus on health outcomes defined by different populations, which could be a geographical snapshot of the population, also looking at populations by healthcare delivery systems. And as Jimmy mentioned, population health is one of the cornerstones of the triple aim as defined by the Institute for Healthcare Improvement. So population health can be described from a clinical perspective or a broader perspective. A broad perspective focuses on the health of all people in a geographic area and emphasizes a multi-sector approach, including non-clinical interventions to address social determinants of health. And population health encourages attention to upstream factors, social determinants of health, and fosters partnerships and shared accountability for population health outcomes. So this diagram is of the social ecological model of health, which I'm sure a lot of you all are familiar with. But an ecological approach to health focuses on health and interventions aimed at improving health at a community or population level, as well as on an individual level. So the most inner circle includes individual level influences that impacts one's health, such as age, gender, and race. And then the outer circles focus on influences such as family, culture, living and work conditions, environmental conditions, and local, state, and national policies. So this model here is the population health model that was developed by the Institute for Healthcare Improvement. And this model illustrates also a holistic approach to health, including the attention to interventions that focus on upstream factors, which includes socioeconomic factors in the physical environment, and individual factors such as behavioral factors and genetics, intermediate outcomes such as disease prevalence and injury, and then also looking at quality of life indicators. So a common set of population health outcomes provides a snapshot and a picture of a community's health. And the data can help stakeholders prioritize prevention activities, build coalitions to make improvements, and address existing problems. And again, this is something that we are already seeing with the different district projects and at the RHP level. A common set of population health outcomes can also facilitate comparisons across different providers, regions, and other populations. And it also can help individuals and stakeholders work collaboratively to improve community health. And the 2016 CMS Quality Strategy actually has population health as one of the components of their strategy's mission. So as Jimmy mentioned, we are working on a district statewide analysis, and it's going to be an ongoing effort, and we're working closely with iChip to kind of gather data at the RHP and statewide level. And so we're looking at selecting health outcomes, like I said, at the regional and state level, and the selected measures include available data that aligns with district projects and state priorities. And the data provided reflects Medicaid managed care data as well as some all-payer data, which is new and exciting. And as a consideration, the data may not always be reflective of the entire district population. And as our DOS and Ashley mentioned yesterday, there are other things to consider when looking at statewide data, but it's important and useful in helping identify broad trends. So the measures that will be highlighted in the statewide analysis plan include some of the potentially preventable events, adult and pediatric quality indicators, utilization of care measures, including outpatient and ED visits, HEDIS measures related to behavioral health, and HEDIS measures related to access to care measures such as breast cancer screening and frequency of ongoing prenatal care. So just wanted to quickly highlight some other statewide and RHP data that is available. We have District Category 4, and on the HHSC Transformation website, there is some data that from 2013 that includes, but it's by RHP and it includes some of the PPEs. And I included the link to that specific page. So accessing state and county healthcare outcome data, there's also the Texas Department of State Health Services Texas Health Data System, which provides a Texas data system that allows you to query DSHS public health data sets for statistical reports and summaries. And data contained in this system includes upstream factors such as socioeconomic measures and downstream factors such as healthcare utilization data. So here's a highlight of some of the health topics that are included in the Texas Health Data System, and much of this data provides that broader perspective of population health. So in conclusion, population health looks at health outcomes of a group of individuals, including the distribution of such outcomes within the group. The population can be defined by geography, health systems, or other similar factors. Population health has been used to describe both a clinical perspective as well as a broader perspective of health that focuses on social determinants of health. And lastly, a common set of population health outcomes can promote collaboration between organizations, assist in considering factors that influence health, and promote individual groups to work collaboratively to improve the health of a community. And that concludes my presentation.
Thank you, Ayana. Next up is Xiaoling Wang. Xiaoling is an economist, and she is the director of our Medicaid CHIP Division Data Analytics Unit, which is a very important position in HHSC and to you, because that means she's really, her and her team are our chief analytics group when it comes to Medicaid health services data, Medicaid claims, and that kind of information. So I don't know if she has a cow anecdote for you or not, but she will have a lot of information about Medicaid claims and the kinds of things that her team does with that. So, Xiaoling.
Good morning, everyone. Thank you, Jimmy, for the introduction. Jimmy and I worked together many years ago, started at the health department back then. We're the young research specialists looking at HEDIS data, and that was, and then he and I started working again in HHSC.
Almost the whole time
It's
I've
whole
been
time,
here.
our career has crossed quite often. And today I'm going to talk about data analytics, have the opportunity to discuss how Medicaid CHIP program apply data analytics to inform its decision makings. I don't have the cow stories. I will work on it next time to find something interesting. I'm from China. There's a lot of interesting saying, but I don't have it today. I'll do better next time. Here's the outline, what I'm going to talk about. I'm going to give a brief overview of Medicaid program to look at the clients we serve, and as a data analytic team, what's our mission and goals, and talk about the things we've been doing to support the Medicaid CHIP program, where we're now in data analytics and in terms of service we offer. And I'm also going to talk about that where we are headed, and in terms of what we plan to provide and the capacity we're building. So here is a brief overview of a Medicaid program. Medicaid is a joint-funded state-federal program that provides medical coverage to eligible needy persons. Currently, we're about serving 4.1 million members. Over 73.5% of them are children. We're working on a budget of $67.9 billion in fiscal year 2016 and 17. Medicaid program used to be mostly a fee-for-service program, but we are moving towards managed care program. Currently, 88% of our clients are receiving medical services through managed care programs. Under managed care program, we have three major models or programs: STAR, STAR Plus, and STAR Health. And then some of you probably know that STAR Kids program is coming, it's implemented this month. Here's the data analytics goals and mission. Data analytics really, there's many people talking about what is really data analytics. It means different things for different people, different subject, and it is use of data to turn the data information into something that is actionable knowledge. So our mission is really proactively support Medicaid CHIP program to make data-driven decisions through data and data analytics. How we do it, we build a team with a talented staff, knowledge of program data, and analytic tools to support a management decision related to compliance with the contractual mandates and the overall system performance in three fronts: to reinforce compliance and strengthen our contract management and monitoring the utilization trends. And as part of a Medicaid team, through these activities, we hope to achieve the triple aim, that is to improve health outcome, improve patient care, and contain costs. So how do we do it? We doing it through detecting trends, identify anomaly through utilization services and cost of services, and the monitoring the provider adequacy. We also work with program area to establish performance measures and monitoring performance over time. We continue to build, enhance our data analytic infrastructure and capacity, increasing data analytic maturity. That is to reduce the time to clean and validate data instead of spending more time to analyze data, asking and answer the crunchy questions. Here in April April this year, we launched the executive and the operations dashboard, a key component of our effort to make data and the results of data analytics transparent and accessible to our program staff. so they can use this information to help them to making policy decisions. Now about 80%, now about over 80 MCD staff have access to this web-based dashboards at any time. The information eligibility, providers, service utilization, compliance, and MCO performance measures can be viewed over by time, geographic area, and then by specific programs. So program staff actually can go in there, slice and dice to looking at information that relevant to the subject they're interested in. For example, the dashboard here provides information on how is the average monthly number of clients for inpatient hospital stays changing over time, how does average monthly number of clients look across state for ED visits, what is the variation over time in number of clients who had a behavioral health diagnosis. Here's a closer look at our ED visits. You can look at ED visits over time by program. You can looking at geographic areas, looking at the total cost, number of clients, cost per client, cost per claim, and the utilization per 1,000 member months. And all this information is still at a higher level, even though we can slice and dice to geographic areas and a program. So with these dashboards we build, you can actually digging deeper, asking more questions. What are the correlations? Where's the outliers? Is there any seasonalities? Here's example of ED visit ranking by diagnosis code. We get asked a lot of questions on that. They said, what is the top diagnosis for ED visits? If you just run the data throughout the year, just looking over at the overall look at ED visits, you don't see a lot of crunchy things you can ask. You know, general symptom is ranked number 1. That really doesn't help us. Acute bronchitis ranking number 7. What can we do more about that? So if you look deeper, so if we plot this over the time, you will see bronchitis was ranking number 7. But if you plot it over through the years, you see there are seasonalities. In the winter months, they were higher ED visit due to bronchitis, and then lower in the summer months. This is just an example that when you did looking into the data a little bit more, you will see some patterns and some trends. And then here's another question people, our staff asking us, what's the frequency of ED visits? So if you're looking at overall numbers, ED visits really is not a huge concern. It's about only people visit ED usually only one time during the year. But if you plot it out this way, you can see that even though ED visits, 61% of clients only had one ED visit, there are some clients, about 8.5% of them has 3 or more visits. So we can ask the question, looking at what's the difference on those clients. So program staff can come to data analytics to ask those more in-depth questions instead of always asking questions at a higher level. Here, we're also looking at following the correlations between the number of visits per clients versus number of total ED visits. In this dashboard, you see the Dallas and Tarrant Bexar counties stands out. Not only they have higher total number of ED visits, they also have higher number of visits per clients. So why? So then this the program staff can asking more in-depth questions. Okay, here come down, after all this example I gave you, we mostly used the administrative data we have in the Medicaid CHIP program, our client enrollment data and provider data, and the claim encounter data. Those are very, those are service information that tells you what happened. And then we spend a lot of time to describe what happened, and then did some statistical analysis on the correlation of certain variables. But to do better, to assist the program staff to answer questions to drive insights, we really need to dig deeper. We need to ask the why questions so we can predict what will happen, what is the impact if a small change is made, finding a solution to a problem, and in turn to be able to alter the behavior and change the course, what to do to make it happen. To do so, we really need more than just administrative data. Data such as vital statistics, clinical data, case management data, and the stuff that you guys have been collecting that is not in a claim, it's not going through a medical claim, might really provide insight of what's going on and answer the why question. So our team going to hopefully in the long run will be able to work with other data to, besides administrative data, to assist the program to better analyze provide better data analytics to answer the why question. And one of the efforts we have been doing is to work with the district program. Judy going to talk about one of the example we're using administrative data combined with case management data to looking at outcome of the district effort. Thank you very much.
Thank you. Thank you, Xiaoling. For our final speaker on the panel, I want to introduce Judy Temple. She's, as Xiaoling mentioned, she's with the Data Analytics Unit. She is the lead analyst for a team that looks at performance measures and performs evaluations. She has a master's degree in social work, which is very fitting for the kind of evaluation that she's working on right now. Her and her team have been digging very deep into the data to evaluate an innovative district project that incorporates social support services in addition to medical services into their care model. And this is very important. A lot of experts really believe that, you know, the best opportunities that we have in this country to improve care, improve outcomes while also reducing cost come in this area of being able to address more the underlying service needs, social needs that people have, those social risk factors. And so it's very important for us to be able to develop credible evidence and comparison groups, and that's what Judy's been working on. And so, Judy.
Good morning. I'm from Boston, and I don't know anything about cows. Sorry. So before I start, I just want to acknowledge my teammates, Nisa Brown and Ellen Sosa, who are not here today, but they're watching. They worked really hard on this project with me, and they're incredibly talented. Every year in Texas, tens of thousands of young adults with chronic childhood conditions transition into the adult healthcare system. This transition can be challenging because it often requires care coordination among multiple providers. I'm short, I know. Okay. So today I'm going to present on our evaluation of an innovative district project called the Transition Medicine Clinic, or TMC. TMC was created to make this transition smoother for clients and improve their health outcomes. TMC has been a district project since 2012. It's based in Houston and affiliated with the Baylor College of Medicine and Texas Children's Hospital. The clinic provides a medical home to around 700 mostly young adults with chronic childhood conditions like cerebral palsy and Down syndrome. In addition to medical services, TMC offers care coordination and case management, which connects clients to community resources. They also provide health education, like when and how to use the emergency department. And district funds have allowed TMC to expand these types of services. I'm grateful to say that TMC's medical director, Dr. Cynthia Peacock, is in the audience today. And she's over there. Maybe wave, thanks. If you have questions about the clinic, she can answer them after the session. The social services provided by TMC are not typically covered by health insurance. So to ensure future funding, it is especially important that the clinic can demonstrate positive health outcomes. One of their stated goals is to reduce emergency department or ED utilization by 25%. Since so many of the clients receive Medicaid due to a disability, HHSC was able to analyze their ED utilization using Medicaid data. So my presentation is going to go over our analysis and share some preliminary results. This is an overview of our method. First, TMC provided us with Medicaid IDs, the client's first and last TMC visits, and primary diagnoses. That allowed us to match their IDs to the Medicaid files to pull their demographics and enrollment history. We limited the study to clients with 18 months continuous enrollment, so we would be sure to have a full picture of their utilization history. Clients also needed to be enrolled during our window of available ED data, which was 2010 to 2015. We used the enrollment data to create a comparison group of similar clients, borrowing from a technique called propensity score matching, which I'll describe in a few minutes. To identify ED utilization, we matched client IDs to the encounter and claim system, and we looked at average monthly ED use and also created a pre-post design to calculate whether any of the changes were statistically significant. These bar charts show the client demographics. We had 261 clients in the study group, and if you can see in the third bar, the age breakdown. Most TMC clients are 30 years old or younger, but about 4% were older. The fourth bar shows their diagnoses, which include cerebral palsy, Down syndrome, spina bifida, and autism. Around 18% had other types of genetic or serious illnesses. So like most clinics, TMC was not set up to be a scientific experiment. Clients needing services were not randomly assigned to a treatment group or a control group. And without a randomized control group, it can be really difficult to say what the results of an analysis really mean. For instance, if we saw a decrease in ED use, we wouldn't know if this might have happened even if they hadn't received TMC services. But because of our access to Medicaid data, we were able to construct a comparison group of similar Medicaid clients who did not get services from TMC. And we did this in a couple of steps. First, we identified clients in the Medicaid data who were broadly similar to TMC clients. They needed to be in the Medicaid program because of a disability, live in the same area of the state, and be between 12 and 60 years old, which is the full age range of the study group. After this first step, we ended up with a potential comparison group of about 66,000 clients. This slide shows the characteristics of the TMC clients and the comparison group after just this first step before we did any propensity score matching, which I'll describe in a minute. The TMC clients are represented on the left side of each pair of bars, and the comparison group is on the right side. The groups are similar in some ways, but there are also some differences. You can see that in the third pair of bars, we have a much higher proportion of older clients in the comparison group than in the study group. 57% compared to 4%. The diagnoses seen in the fourth pair of bars are also pretty dissimilar, with the other diagnosis category being very large, 86% compared to the study group, which is only 18%. And these differences are really important because they can interfere with how we interpret our results. For example, if we find that ED use for TMC clients decrease more than for the comparison group, We would not know if it was because TMC services made a difference or just that TMC clients tend to be younger than clients in the comparison group. So to correct for these imbalances, our second step was to use a technique called propensity score matching, or PSM. PSM gives each client in the treatment and potential comparison groups a score, which represents how likely it is that the client would be in the TMC program based on things like their age and diagnosis. The score ranges from 0 to 1, with 1 being the most similar to TMC clients. Potential comparison group clients are then matched on a one-to-one basis with TMC clients with a similar score. Our propensity score is an aggregate of the variables listed on this slide, and they're qualities that impact whether or not a client would receive TMC services, such as having a certain type of diagnosis. There are also characteristics possibly related to a client's level of ED utilization. This is how we set up our time frame for our analysis. There are basically 3 6-month periods over a total of 18 months. Period 1 is the 6 months before the client's initial TMC visit. Period 2 is the 6 months after. And period 3 is the next 6 months after that. Since the comparison group did not get TMC services, we randomly assigned them a TMC-like initial visit based on their Medicaid enrollment history. Sorry, that was the slide of the time frame. So our first calculation, these are some of our results, was the average number of monthly ED visits over the 18-month study period. The black line is the study group, and the gray line is the comparison group. You can see that the groups show a similar downward trend before the intervention and even a few months into the intervention. However, the TMC group continues to decrease in the last 6 months, while the comparison group remains relatively stable. This graph shows the results of our pre-post analysis. We compared the number of visits in period 1, which is, again, is the 6 months before TMC, to periods 2 and 3, to see if any of the changes were statistically significant. The left side shows the study group, and the right side shows the comparison group. For the study group, from period 1 to 2, the number of ED visits decreased 26%, and from period 1 to 3, it decreased 33%. And the change from period 1 to 3 was statistically significant. On the other side, the comparison group decreased 25% from period 1 to 2, which is very close to the study group. From period 1 to 3, the decrease narrowed to 17%. Neither of these decreases were statistically significant. So as I said at the beginning, these are preliminary findings, and we're still working on the analysis. But so far, we have found that ED visits for TMC clients decreased by over 25%, which was the project's stated goal. In fact, it decreased by 33%, which, if I remember correctly, Ardest said was the average decrease in the Category 3 outcomes. For both groups, ED visits decreased at first, but the TMC group continued its downward trend toward the end of the study period. And from period 1 to 3, that change was statistically significant, as I said. So what do these results mean? They may suggest a more sustained change in the study group. However, we will need to track utilization over a longer period of time. Dr. Peacock, the medical director, has told us that they tend to see ED use decrease after clients have been in the clinic for about a year or so. So it will be very interesting to continue to track longer-term data. In addition, we continue to refine our method to make sure that we have the strongest model possible, and we're conducting analyses to clarify which factors best explain the differences in the results between the groups. ED utilization, of course, is only one outcome measure, and next steps may include looking at other metrics of interest, like cost of care and inpatient admissions. And that's the end of my presentation. Thank you.
So that's the, those are our panel presentations. I'm not sure how much time we have for questions. We're getting up close. I think maybe we have time for 1 or 2 questions if you have any, but First, I just, again, want to thank our panelists and all the great work that's going on in the HHSC to look at data and try to make it as meaningful as possible. I know there are a lot of tools that they've just touched on and that are available also to you to help support the work that you're doing. I think that's what's most important, is for you to have a good idea coming out of this session about what kinds of data we have available in the state to support the work that you're doing in your region. So always feel free to contact me or Ardas or anyone on the panel if you have questions or are looking for some kinds of information. And with that, do we have any questions?
This is for Noel. Sorry, Ajay Vitalam from UT Health Science Center at Tyler. Just a quick question on the category 3. Is there a specific reason why the achievement targets are set at 25%, 50, 75, and 100? And is there any plans to change going forward?
That's the partial achievement.
Yes.
I don't know the reason, but those are sort of the numbers that were agreed upon as part of the Category 3 framework with CMS. So I don't know if other states are doing partial achievement in terms of their outcomes, but I think that might be a pretty common breakdown in terms of disparate projects nationwide.
Because when you measure data, when you have achievement which is greater than 25, you're not realistically capturing that effect of what your data is really saying.
Mm-hmm.
So probably you should change that particular approach.
Other questions? Well, I have one question for the panel, I think, and maybe directed towards Charlene, but really towards all of you. What kind of considerations do you think go into making the information that we have most useful for decision making?
So do I turn this? Does it work? Okay. Hi. From my experience, and like Jimmy and I both work for health data, working with health data for a long time. I think data is there, but I think the most important thing that is to have that data available to program staff, to the policymakers, so we can work as a team, not always just supplying the data. I think the tandem between program area and the analytic team work together, we can actually understand our data better. Data alone cannot help do the job. It's really of a teamwork.
Thank you. Any other questions? Are we good on time? Okay. Well, thank you all for your participation, and feel free to talk to any of our panelists. After they'll be here for the proceedings today. So again, thank you all.
Hi again, everybody. I've got a couple of slides that we want to highlight some RHPs. We want to start with RHP 10. Which is one of our bigger RHPs. It is 9 counties that covers 7,221 miles, and that's 2.4 million people. The regional growth over the waiver period is projected at nearly 10% and up to 2.7 million residents regionally. 4 of those 9 counties are also designated as partial primary care health professional shortage areas. And we want to give a highlight to JPS, and I know Heather is here and probably some of her other team members. Where are you? Hi, guys. JPS has implemented a project to improve care transitions and health outcomes for the Tarrant County homeless population. Their multidisciplinary teams, medical, behavioral health, advanced practices, paramedics, and care transition staff are deployed to provide services on the streets, in the shelters, or in supportive housing. 64% of patients reduced ED utilization rates 12 months post-intervention, which is great. We also want to look at RHP 18. I'm kind of excited to say this word out loud, contiguous to both Dallas County and the state of Oklahoma. Fluid movement of healthcare consumers in the Metroplex, and it has a total population of about 0.9 million. We want to highlight the Children's Medical Center of Dallas. Do we have anybody here today from the Children's Medical Center? I'm sure you guys are watching. The Children's Medical Center of Dallas is bringing behavioral health services into the primary care setting through My Children's offices in RHP 18. They have a follow-up care for ADHD. They've improved from the baseline of 64% to 75% and have met 100% of their goal. All right. So some housekeeping items. Number one, if you guys are sitting around the perimeter and you want to eat, please come sit at a table. We've got some open seats up front. Second, you don't have to leave the banquet hall today. Salads will be brought to you as you are seated. If you have a vegetarian card, please place that at your table. If you would like iced tea, that is available on request. I think that's it for right now. All right, thanks. We'll eat soon.